Hi guys, we're going to get started in the interest of time. And just for some housekeeping, please at the end of every presentation, if you guys have questions, please use the microphones so that we can answer your questions. So our next presenters are going to be Marcy Victory Stewart, Nurse Manager of Cardiac Surgery ICU, Cardiac Step Down, Keiko Iwama, Cardiac Surgery Staff Nurse, and Mallory Montalvo, Clinical Quality Nurse Specialist, and they're going to talk about a new graduate fellowship program in the CSICU. Guys, come up.
Thank you, Dr. Freeman, for the introduction. My name is Keiko Iwama. I am a cardiovascular surgery ICU nurse. First, we will discuss the needs for a nursing fellowship by describing our nursing folks. There is an increased demand for qualified nurses and limited supply. In nursing education, there is a shortage of qualified faculty and a shortage of clinical sites for nursing students' hands-on experience. Current nurse workforce is affected by high turnover of bedside nurses, especially after COVID-19 pandemic, and high turnover of new graduate nurses. There are challenges in transition to practice. New graduate nurses often experience difficulty during their transition to practice due to a lack of clinical experience, and there is a theory practice gap from academic to clinical setting. Because of this, they tend to experience high level of anxiety, fear, and frustration in the first 1 year of their clinical practice. There is an issue with high turnover rate within the first and second year. The first year turnover rate is 70.5. The second year is another 16%. The average cost of turnover for one bedside registered nurse is over $50,000. It affects organizational performance as well as quality of patient care. So we look at the benefits of fellowship program to support and educate new graduate nurses. A variety of outcomes of robust transition programs are identified from literature, such as increased clinical competency, clinical leadership skill development, role socialization. It includes better performance within the teamwork in the nursing unit, improve clinical thinking skill, time management skill, boost up self-confidence, increase engagement and commitment towards their work and towards their organization, increase work satisfaction. It affects higher retention. 1 year retention rate within transition programs is much higher than overall national average. So, what is the robust transition programs? We reviewed literature in order to develop a fellowship program. These are major highlights: development and implementation of a standardized format. These programs increase success. 1 year curriculum is much more effective than shorter term. In addition, combination of comprehensive nursing orientation and specialty training with a different focus. In our case, focusing on cardiac critical care. Moreover, offering monthly seminar sessions with a variety of topics in the nursing. Lastly, identify needs for supply by trained preceptor and enough time to practice skill under the guidance of trained preceptors. Now, I am going to pass on to Nurse Manager Marcelina Victory Stores to discuss further.
Thank you, Keiko. I want to say next slide, please. So a little bit of background about 6 East. 6 East is a closed unit consisting of 26 beds. 12 of these beds are dedicated to the recovery of post-op cardiac surgery patients, and 14 are for the CCU, the non-surgical patients. We are a team of intensivists who are on the unit round the clock, physician assistants, nurse practitioners, as well as physical therapists, nutritionists, and social workers. Nurses are cross-trained to work on either side of the unit and attend yearly competency classes and in-services to maintain and assist in hemodynamic emergencies, EKG, ABG, and lab value interpretations. They manage ventilators, intra-aortic balloon pumps, impellers, CBVH, aquapheresis, temporary pacemakers. Nurses also titrate inotropes, vasopressors, and anti-arrhythmia medications based on orders. It's a moderately sized program. Approximately 500 surgeries are performed yearly. They include on and off pump CABGs, all arterial grafting CABGs, valvular and aortic surgeries. At Mount Sinai Morningside, our program has received a 3-star rating for 6 consecutive years. This is the highest rating awarded by the Society of Thoracic Surgeons. This is in part due to the excellent delivery of care from our nursing team that consists of 52 nurses, 4 of whom are ANCCs or supercharged nurses. They are responsible for the unit's flow and operations and act as our unit's resource for assisting the nurses in resolving unit-based issues as well as issues that involve patient recovery. 6 of the 52 are our new grads from the fellowship program, and a whopping 41% have their CCRN, with more on the way. So post-COVID and the retirement of baby boomers has seen an increase in nurses leaving the bedside nationwide. And Mount Sinai Morningside was not immune and sought new graduates to increase the number of nurses who could be placed in our cardiac surgery ICU. Here we thought we'd get new grads in, and we can mold them to what we want, create our super cardiac surgical ICU nurse. We needed more nurses to provide, we need more nurses to provide for the specialized care we offer our patients with serious cardiovascular diseases. And the post-op care of the cardiac surgery patient requires highly specialized trained nurses that can identify, react immediately and efficiently to the dynamic and subtle changes to patients in their care. In order to do so, we have to provide them with a comprehensive training curriculum in the practice of cardiovascular intensive care nursing. This curriculum will enable them to acquire the skills and knowledge and the ability to care for our patients in this setting. So what was the criteria for admission into our fellowship program? Candidates must have possessed or completed a BSN program in satisfactory record, have successfully passed their NCLEX exams, demonstrated a strong inclination towards pursuing critical care nursing, and provided a compelling rationale for their interest. In my opinion, the interview process was the most crucial part of this criteria. There were a multitude of interviewees. I sought candidates who possessed at least 100 critical care clinical hours or had worked as a nursing assistant in a nursing care, intensive care unit or a different unit, or had completed an externship in an ICU. Additionally, I required all applicants to have a fundamental comprehension of heart function. I requested candidates to provide a concise explanation of the PR interval. I wanted to assess their knowledge and their ability to apply what they learned in school to arrive at the correct answer. I inquired about their study habits during their time in school, as I clarified that a substantial amount of studying would be necessary to excel in the cardiac surgery ICU. I also possess an unwavering confidence in my own intuition. I was particularly drawn to candidates who inquired about my expectations of them and the structure of our curriculum. The next few slides, you'll see if my instincts were right.
The structure of our fellowship program was a 32-week series with the option of an extension if needed. Week 1 consisted of central nursing orientation, which introduced the new graduate nurse to the Mount Sinai Health System. Week 2 consisted of the essentials of critical care orientation, also known as ECHO. ECHO was developed by the American Association of Critical Care Nurses and is an interactive online platform featuring up-to-date, evidence-based education that supplemented our unit-based orientation. Week 3 and subsequent weeks, the fellowship nurses immersed themselves in classroom lectures. We utilized our own team RN and expert, Fred Dunow, to follow every step of their journey to become successful ICU nurses. Week 4, the new graduates shadowed the procedural areas. This included the cardiac cath lab, EP lab, and echo to observe the process of diagnosing potential surgical and non-surgical candidates. Week 5 to 8, the new graduate nurses were trained on the step-down unit to get acquainted with the care patients received when they leave the ICU. They continued to attend lectures and visit the simulation lab to work on patient care scenarios. In addition, great emphasis and practice was placed on report handoff using the SBAR format. Week 9 to 32 was a critical care orientation specific to 6 East. The cadence of the program began on the CCU, progressed to the CSICU, and culminated in the fellows having to admit at least 10 hearts before being considered to practice independently. We altered their shifts to gain the best possible experience and exposure. For example, they came in at noon so they could admit hearts, or came in early on the night shift so that they can have longer experiences with the post-op patients. They learned how to set up a room to receive a post-op cardiac surgery patient, inventoried the contents of the code cart, reviewed EKG interpretation, hemodynamics, and ABGs. All these topics were accompanied with exams. They had in-services and interactive training in the management of ECMO, intra-aortic balloon pump, ventilators, CVVH setup, aquapheresis, and external pacemakers. Our ultimate goal during their orientation experience was to be a resource and foster an environment of learning. We utilized different modalities of learning. The first was independent study. This consisted of a personalized binder that contained their orientation schedule, lectures, homework, report sheets, and any other educational materials they wanted to include. Our Cardiac Bible is a 100-page document that outlines all topics cardiac surgery related. It's utilized as a reference, and the expectation was that the new graduate nurses would always have their binder and Cardiac Bible on them at all times. Next, we implemented group learning, which consisted of bi-weekly lectures and Zoom meetings. The Zoom meetings were utilized as an open space where the fellows could freely ask clinical and non-clinical nursing questions. Lastly, there were weekly modules that consisted of homework and clinical experiences. The homework was a weekly head-to-toe physical assessment, a process map for diagnoses, and pharmacological management. So how's it going now? Where are they? All 6 new graduates finished orientation and are practicing independently, and this is a picture of them when we threw a little graduation for them. These are personal statements from our fellowship nurses. At first, I was very scared. Now I am beyond excited to be functioning in an independent fashion, knowing I have support from the staff. Some of the unit was reluctant to accept new grads and was not the most accepting at times to change. I had a great preceptor who helped me learn a bunch. There were also people on the unit who went out of their way to teach as well. Feedback from the 6 East staff included how the fellowship nurses fostered 6 East's sense of cohesiveness and teamwork. We are so proud to have been able to participate in this program and look forward to seeing our fellowship nurses grow professionally. Thank you.
Does anyone have any questions? Oh, you gotta use the microphone, Mackenzie. Oh. Yeah.
What do you think the biggest factors were to retaining the nurses?
I think.
The new grads, rather.
Part of the thing that's, we listened to them when we paired them. One of the most important things I think we found is when we first paired them with someone we thought was going to be a good match, and it wasn't. So we moved them around to find that perfect match for them. We also listened to what their needs were. Some of them were coming in at 7 a.m., the others were coming in at 7 p.m., and changing their curriculum to get them the best experience also helped them. You know, they were exposed to more things than I was when I was on orientation. ECMOs, balloon pumps, impellers. I never had that. And, you know, I had to be a nurse for 4 or 5 years before I even saw that. So they had a lot of that excitement. And we made sure that they were put took care of those patients immediately. And then, of course, Freddie always supported their learning skills with that. But moving around their precepts, some people used to say, oh, they're moving around too much. But when we didn't, they weren't learning. But then when we found that perfect match, they were learning. Then people volunteered, like Nikki, volunteered to take them on throughout their whole journey. She said, oh, I want to help this person, and that's it out. And she's one of the most successful, the one that the team talks about the most and says, I can't believe this one here is doing so well, and she's so assistive now, so very proud of that.
I also think having Fred, he was available 24 hours, 7 days a week if they had any questions. They felt very comfortable reaching out to him. He's also just a wealth of information, so having that support system and that resource was a game changer.
But I also just want to add that, you know, the support of the leadership of the team was extremely important as well. I know Marcy made a conscious effort to meet with them one-on-one, checking in with them, seeing how they were going, and even when they had negative things to say, as you saw, there was a negative comment, you know, and supporting them and working them through. And Fred, who was their super preceptor and educator, was also their mentor. And I think just the support of everyone just really helped them over the finish line and really helped with the retention. I just wanted to add that.
No, that's right, because they do practice safely and independently. They have a lot to learn, and they recognize that. They also have that imposter syndrome because everybody around them is, you know, knows so much. So they're eager to learn what everybody else knows.
Any other questions?
Thank you.
Thank you.
Our next speaker is going to be Dr. Tia Coleman, who is the clinical program manager for our cardiology NPs at the Mount Sinai Morningside, and she's going to be talking about women and heart disease. Why did we even think that women had less heart disease?
Thank you, Dr. Friedman. Hello, everyone. Thank you for coming today and listening to these great presentations we've had so far. So today I'll be talking to you about women and heart disease. As we know, men and women are different. And I'll give you a little example here. As you can see from this depiction, we have the men, little one button, and we have 1,000 buttons. This is just a generalization. Not everyone's the same, but so many times we treat a disease process without taking into consideration the gender differences. So let's look back in history for a moment to go back to the 1960s when this all started with women and heart disease. So the American Heart Association in 1964 had their first conference for women on heart disease. So the title was Hearts and Husbands. What that had to do with women, I don't know, but that was the title. And the objective was learn how to keep your husband's heart healthy. Not your own, but your husband's. This conference was conducted in Portland, Oregon, and there was 1,000 female participants. So let's go over some statistics. So heart disease is the #1 killer of women in the United States. It kills 500,000 women each year. Women are twice as likely to die from a heart attack than men. But despite these figures, very few women view heart disease as their biggest health threat. So a survey was conducted by the National Center for Health Statistics, and women themselves rated breast cancer as the #1 health threat, followed by unspecified cancer. And as you can see, heart disease is way down on the list there, right above ovarian and uterine cancer at 3%. And the actual statistics are heart disease is the #1 cause of incidence health threat for women, and breast cancer is below that at 4%. So factors influencing diagnosis of cardiovascular disease in women. The risk of heart disease is underestimated in women by women themselves and by physicians. the role of the woman's demeanor. As we know, like if we have chest pain, we're like, oh no, it's not anything, it's just heartburn, we're fine, we keep moving, get the job done. The physician's estimate of cardiac risk and the patterns of angina. Angina with exertion occurs similarly to men, but is more frequent with rest, sleep, or mental stress in women. The presentation for men is a typical angina, the substernal, this crashing, squeezing, shortness of breath, occurring with exertion, relieved at rest, lasting more than a few minutes, radiating to the jaw or the left arm. In women, we do have some typical angina symptoms, but it's mostly atypical, with mostly being shortness of breath, neck or jaw pain separately, nausea, palpitations, weakness, and fatigue. So this graph diagram shows that the differences between men and women. Mostly, if you see the women are in purple and the men are in blue, men most likely have the chest pain, and the women's mostly symptoms are fatigue, shortness of breath, and weakness. And again, same thing, another graph just depicting where men most likely have chest pain, 100%, and women, their greatest is really stomach pain or back pain. And again, also the characteristics of the pain, the pressure. As you can see, the women are in black and the men are in white. The women have more, and undefined pain is also higher in women. Now, are there gender differences in non-invasive diagnostic tests? So when someone presents with chest pain, you want to start with the most non-invasive stress testing. So that will be an exercise, treadmill, bike, or pharmacological stress test, and cardiac monitoring with the EKG, or additionally, nuclear myocardial perfusion, imaging, or echocardiography. So exercise stress tests in women, it's inexpensive, it's easy to perform, there's low sensitivity, low prevalence of multi-vessel disease, there's low specificity with non-specific ST changes in women. The nuclear stress myocardial perfusion imaging in women, there is some deal of radiation exposure. There is a high level of breast tissue attenuation artifact. There is larger and more extensive defects identify women at higher risk for more severe ischemic heart disease and cardiac events, but negative scans are helpful in excluding ischemic heart disease. When we talk about stress echoes, there's no radiation exposure. They determine the functional information about the heart is provided. It's difficult in patients with poor echo windows, for example, those with COPD and obesity, and there's poor sensitivity in single vessel disease. And cardiac catheterization, it provides direct visualization of coronary arteries. It is the gold standard. It has 100% accuracy as you're actually going inside the arteries to determine if any of these blockages are occlusions. Cardiac CTA looks at the arteries and the chambers. It's high spatial resolution, there is radiation exposure, and it's best in those without coronary calcium. Cardiac MRI assesses the function and structure of the cardiovascular system. It can identify infarct, evaluates blood flow to the heart muscles. There is no radiation exposure, but it is very expensive. So where are we with diagnosing CAD in women? So typical chest pain is less likely to be CAD as it usually presents atypically, as stated before. Stress testing is less accurate in women, but we should always start with an exercise stress test. Even normal coronaries on catheterization does not guarantee that women will not have coronary events. So this algorithm is really for women that have intermittent high likelihood with atypical or typical chest pain symptoms. Also, there's a lot going on here, but if you just look at if someone who has normal rest EKG and they're able to exercise, we should always firstly recommend an exercise stress test. If they have diabetes, abnormal rest EKG, or questionable exercise capacity, we should go for a stress cardiac imaging. If they're able to exercise or they have a history of symptoms with low-level exercise, then exercise stress. If they're unable to exercise due to maybe orthopedic issues like maybe knee pain, back pain, or they have a CVA or a left bundle branch block, you should just go for a pharmacological stress test. So some guidelines for CV prevention in women. We use, the American Heart Association likes to use a 5-step approach, and the mnemonic is ALOHA. So for A, it's assess and stratify women into high, intermediate, lower, and optimal risk categories. Lifestyle modifications, other cardiovascular disease interventions, including the treatment of hypertension, diabetes, hyperlipidemia. Highest priority for interventions in high-risk patients. Avoid initiating therapies that have been shown to lack benefit or where the risk outweigh the benefits. So for risk stratification, major risk factors include a woman of age 55 or greater, smoking, hypertension, whether it's treated or not, hyperlipidemia, and a family history of premature cardiovascular disease. Cardiovascular disease equivalent, also risk stratification, include those with diabetes, those with atherosclerotic disease, and chronic kidney disease, especially those on end-stage renal disease. Diabetes automatically places a patient in a high-risk category, and family history is defined as cardiovascular disease in a first-degree female relative less than 65 years old or a first-degree male relative less than 55 years old. Here we have what we call the coronary heart disease prevention iceberg. It's a risk, prediction. The low level is less than 10%, intermediate is 10 to 20%, and high is greater than 20% of establishing heart disease. So for very high-risk women, they've had a recent heart attack or known CAD along with one or more of the following: multiple major risk factors, particularly diabetes, severe or poorly controlled risk factors, including smoking, multiple risk factors for metabolic syndrome, especially high triglycerides and low HDL. For high-risk category, they have established coronary artery disease, carotid artery stenosis, peripheral artery disease, abdominal aortic aneurysm, diabetes, and again, those patients with chronic renal disease, specifically end-stage renal disease. For the intermediate risk, they may include women with metabolic syndrome, especially women over the age of 60, or with individual factors that are markedly elevated or severe. It also includes women with multiple risk factors, and may include women with subclinical cardiovascular disease, especially elevated coronary score, calcium score. For the lower risk individuals, it may include women with one or more risk factors. It may include women defined with metabolic syndrome if no individual factor is severe or markedly elevated. It may include women with no risk factors, but non-optimal lifestyle factors, such as lack of regular exercise or a high-fat diet. For optimal risk, or less than 10%, they have optimal levels of risk factors, and they follow a heart-healthy lifestyle. So we all know about modifiable and non-modifiable risk factors. For the modifiable, it's cigarette smoking, high blood pressure, diabetes, hyperlipidemia, physical inactivity, and obesity. How do we get results? So a simplified approach to cardiovascular disease prevention helps increase adherence to guidelines, because we know compliance is a major issue when it comes to any kind of therapy. This can be achieved by using an ABC format to present important lifestyle changes and pharmacological therapies. So we say know your ABCs, and I also say D and E's. For A's, you want antiplatelets, ACEs and ARBs, anti-anginals, blood pressure control, beta blocker, cholesterol management, and cigarette smoking cessation. You want to follow their diet and weight management, diabetes prevention and management, exercise, and ejection fraction assessment. So for management of the ABCDEs, for the A's, you want to treat all high-risk patients with at least one of these three medications: antiplatelets, ACEs, ARBs, or anti-anginals. You want to optimize their blood pressure. And you want to relieve the anginal symptoms, which will allow the patients to exercise. For blood pressure control, you want to maintain for a blood pressure less than 130/80. Anyone post-MI or low EF, you want to have them started on beta blockers. For cholesterol management, you want to also target these LDL targets and HDL based upon the chart here. And of course, always cigarette smoking cessation. For dietary weight counseling, you want to achieve the optimal BMI. For diabetes, you would like to have the hemoglobin A1C at less than 6, and always improve physical exercise. You want to aim for at least 30 minutes a day, as long as they can tolerate it. And also awareness, education. Okay, so now we're going to have a couple of case studies. This first case study. So women in heart disease has always been near and dear to my heart because it touched me personally. This first case study is a family member. So 50-year-old woman. Okay. Risk factors: smoker, hypertension, mildly overweight, sedentary lifestyle. What I didn't put on this slide is also stress, because we also know that that is a huge risk factor. So stress for occupation: nurse, director of nurses for the ICU, one of the hospitals in Queens. So the symptoms: she had right shoulder pain. Okay? Now, we all have relationships with the doctors that we work with. So, we have little aches and pains. We go to the doctor, hey, I have this. And So she went to one of her colleagues, exactly, went to one of her colleagues, I'm having some right shoulder pain, I think it's my bursitis. So the doctors, did a little assessment and said, you know what, it's probably your bursitis, just take an anti-inflammatory. Later that day, they had a retirement party for one of their colleagues. So she's out there on the dance floor, and then she passes out. So luckily, right away, everyone started CPR and did everything they could. So her diagnosis was a massive fatal MI. So this is why it's atypical symptom, right? So anytime anyone comes in with any kind of symptoms, we should always automatically just assume that it could be coronary related and not just bursitis or something else like that. Okay. Second case study this is also a true story, but not a family member, just a true story. So this is a 41-year-old female. She has no risk factors at all. She's fit, she's athletic, she rides her bike, weather permitting, 4 miles a day. And if she can't go outside, she's on the treadmill. Only symptom she developed was recently shortness of breath when she was riding her bike. So she had all the tests and everything. Her diagnosis was 2-vessel CAD, and she underwent CABG ×2. And this is someone who's 41 years old. So we would be like, oh, she has nothing. She's too young for this. But again, we always have to make sure that we err on the side of caution when it comes to any kind of, with women, it's particularly, and heart disease. Okay, so in summary, we're still learning about the pathophysiology of ischemic heart disease in women. One thing we know for sure is that we do present with atypical symptoms. More non-obstructive coronary disease with bad outcomes. Chest pain likely represents ischemic heart disease. Diagnostic tests are more complicated in women. And 80% of ischemic heart disease can be prevented with lifestyle changes and risk factor modifications. In conclusion, do not ignore symptoms in women. Do additional testings. And again, you can do a simple EKG. You can get a lot of information from a simple EKG. If the stress test is negative by imaging and the Duke treadmill score is low, proceed to cardiac catheterization. If the stress test is positive by imaging and the cath is negative, still treat aggressively. You can start an aspirin, a beta blocker, an ACE, exercise training. And always risk stratify women and aggressively reduce their risk. So before I end, one last thing. Thank you for your attention. I really appreciate it. I'm going to ask everyone in this room, because this is so near and dear to me, if you could all do me a favor, because awareness is the key to prevention. So whatever you learned today, if you could just share with any woman or male in your life, then they'll share with other people. Before we know it, thousands of people will be aware, and awareness is prevention. Thank you very much.
This reminds me, I don't know who was with me when we went to the Go Red Luncheon, and Susan Lucci, who played Erica King, was speaking about how she had atypical symptoms. I can't remember exactly what she said her symptoms were, but she kept ignoring, and finally, I think she passed out too. Her husband took her to her physician, and she had to get stents placements. And I remember her speaking at the AHA Go Red. Who was with me? I feel like someone was with me. It was you, right? Someone was with me. Do we have any questions for Dr. Tia Coleman? Thank you. So our next speaker is Dr. Aparna Chopra. She is the assistant professor of the Institute of Critical Care Medicine at Mount Sinai Morningside, and she is one of the staff intensivists in our cardiac ICU, and she'll be going over fast-track extubation this morning. Well, it's this afternoon now, right?
All right, thank you so much, Shauna. As you mentioned, so my name is Aparna Chopra. I serve as the intensivist in the CTICU and CCU at Mount Sinai Morningside, and it is my distinct pleasure to talk to you today about fast-track extubation. So let's go ahead. So early extubation was first described by Prakash et al. Back in 1977. They surmised that any patient who has undergone cardiac surgery should be able to take their first spontaneous breath either immediately after or within 3 hours of their open heart surgery. So using careful pre- and intraoperative assessment, they were able to identify 123 patients out of 142 patients whom they proceeded to extubate within 3 hours. So of these 123 patients, only about 5 needed reintubation. So that is about 4% reintubation rate. Of these 5, only 3 3 of the patients had no respiratory indication. They had some other complication which required reintubation. So this was already something that was introduced back in the 70s. So fast-track cardiac care comprises of a series of interventions. It is a multidisciplinary approach, and it is designed to reduce perioperative morbidity, ICU and hospital length of stay, and thereby it improves cost containment. So now there's been considerable disagreement as to what really constitutes early extubation. So there is some consensus, and it is as follows. Ultra-fast extubation is within 1 to 3 hours of cardiac surgery. Early extubation typically is within 4 to 6 hours, so less than 6 hours of the patient coming into the ICU. That counts as fast-track extubation. And prolonged intubation is greater than 24 hours post-cardiac surgery. Now, where this becomes very important is when we're looking at our STS scores. So under the STS scores, one of the major domains is risk-adjusted major morbidity. And of this, we look at the percentage of patients that have 5 major complications. Number 1, re-op. 2, stroke. 3, renal failure. 4, sternal wound infections. And number 5, prolonged intubation. So it can serve to reduce your STS score. So what are some of the advantages of fast-track extubation? Number 1, less sedatives are used. If a patient is not sedated for long periods of time, you can unmask any pain symptoms. If we appropriately treat their pain, they're going to be more likely to be extubated quickly. Rapid mobilization, less time on the ventilator means these patients can be out of bed to chair and ambulating on post-op day 1. They can also have less pulmonary complications such as ventilator-associated pneumonia. This leads to decreased length of stay, and it minimizes resource utilization. So what are some of the disadvantages? So a patient who is extubated too early is going to go into some sort of distress. They're going to become tachycardic, hypertensive. Tachycardia will increase myocardial oxygen demand, which will lead to myocardial ischemia. Of course, wide swings in blood pressure, especially hypertension, is going to lead to an increased risk of mediastinal bleeding. If a patient is extubated without having their pain adequately controlled, they're not going to be able to take deep breaths. This is going to lead to splinting and atelectasis, further compounding hypoxia and leading to reintubation. Also, patients who undergo large volume resuscitation intraoperatively or postoperatively are more likely to become fluid overloaded, which will lead to ventilatory compromise. So what are some of the favorable factors for early extubation? So younger patients with lower BMI, if they have no other underlying conditions such as COPD, asthma, uncontrolled diabetes, if they receive lower doses of opioids or sedatives intraoperatively. So this is why our cardiac anesthesiologists are so good at identifying potential candidates for fast-track extubation, and they really try to use short-acting sedatives and opioids. Shorter bypass times, of course. Mount Sinai Morningside is so privileged to have surgeons who are proficient in both on-pump and off-pump CABG, so we have quite a big population of both surgeries. And historically, patients who undergo off-pump CABG have faster extubation times and reduced ICU length of stay. So according to the Bojar Manual of Perioperative Care in Adult Cardiac Surgery, patients who are excluded from early extubation are cleverly divided into these criteria. Preoperatively, if a patient has pulmonary edema, if they're intubated, if they are in cardiogenic shock requiring inotropes, or if they're septic, we're not rushing these patients to extubation postoperatively. Intraoperatively, if they undergo deep hypothermic circulatory arrest, which happens in potentially aortic arch reconstructions, or if they're profoundly coagulopathic requiring a lot of transfusions, if they have severe myocardial dysfunction, or if they have long bypass times greater than 4 to 6 hours, this precludes them from early extubation. And postoperatively, which is what we see the most, is patients who have mediastinal bleeding, hemodynamic instability with escalating pressors, inotropes, even requiring mechanical circulatory support. if they become hypoxic when we're trying to wean them from the ventilator, and patients who don't appropriately wake up, follow commands, if we're concerned that they've undergone a stroke. Until we have better imaging studies, we have to maintain a secure airway. So in my reading, I came across this review article by Gennady. This was published in European Journal of Translational and Clinical Medicine. There's a number of studies that are shown here in tabular form, ranging from 2001 to 2020. And what their strategy was early extubation. They found that these patients have shorter ICU and hospital stay. They also noticed that there's a decreased cost because there's less chest x-rays, ABGs that are being performed. And of course, the common reasons for reintubation was respiratory insufficiency if they're requiring reoperation or if they're developing a pneumonia. Now, the other striking thing is that none of these studies are prospective. They are either retrospective or observational. So one such observational study was published in 2022. It took place at an academic tertiary center. And they found that out of 472 patients, they implemented a 3-hour fast-track extubation protocol. So about 255 patients were identified and underwent 3-hour fast-track extubation, or FTE. And this was an effective tool to reduce the duration of mechanical ventilation after a series of cardiac surgical procedures. However, they did not see a decrease in the ICU length of stay, and we'll talk a little bit about why that might have happened. So some of the patients excluded from this, of course, if they had mediastinal bleeding more than 200 cc's per hour, a lactate greater than 4, if they required mechanical circulatory support, or inhaled pulmonary vasodilators. So bringing your attention to this graph, so on the x-axis here, we have extubation time in hours. The y-axis is the percentage of patients extubated. The solid blue line is the pre-3-hour FTE protocol, and the dotted red line is the post-3-hour fast-track extubation. The shaded parts are the confidence intervals, okay? So what we see here is that the median ventilation time before this 3-hour fast-track extubation was about 4.43 hours, and post was about 3 hours, which makes sense. The percentage of patients who were extubated within 3 hours prior to this protocol was about 25.8% and about 49.4% post. Coming to this forest plot, so on the x-axis you see the hazard ratio. A hazard ratio of 1 means that there is no difference between your control and intervention. Any hazard ratio less than 1 means that these patients were more likely to be extubated fast track within that 3-hour period. Anything greater than 1, of course, means that they were less likely. So these are the factors listed on the left-hand side. We look at our p-values to see if they're statistically significant, and the horizontal bars are our confidence intervals, and of course they should not cross 1 in order to be statistically significant. So if a patient was sedated with Precedex, and if they were extubated within those 3 hours, their hazard ratio was less than 1, and the p-value was less than 0.001. And of course, if their procedure was other than CABG AVR, if they were admitted after hours between 6 p.m. and 6 a.m., or if they had a longer procedure duration, they were much less likely to be extubated early. The other factors like age, sex, race, BMI, COPD, and reduced sternotomy did not have very statistically significant results. However, they were less likely to be extubated early. Coming to Mount Sinai Morningside. So at our institution, our cardiac anesthesiologists identify patients who are ready to be fast-track extubated. They arrive on PRVC ventilator mode. They are on 100% FiO2. And then we begin our work. So really the fast-track extubation is to empower nurses and respiratory therapists to lead the way and start weaning sedation and FiO2, and then begin the process of pressure supporting and extubating. So of course, if the patient is hemodynamically stable, they're not requiring escalating inotropes and vasopressors. If their cardiac index is above 2.2, their chest tube output is reasonable, they're not having active arrhythmias, then we proceed to weaning their FiO2 and starting pressure support trials. Now, at any point while we're pressure supporting them, if they become distressed, tachypnic, tachycardic, hypoxic, they're not waking up fast enough, or if they develop hemodynamic changes, we do the safest thing, keep them on the ventilator, treat the underlying cause, such as pain, and then reassess and try again. So how do we optimize early extubation? So preoperatively, patients, especially those who have COPD, have extensive smoking history, we really should be getting PFTs with room air ABGs. We counsel our patients on smoking cessation. We treat underlying causes, optimize them for any underlying pulmonary or cardiac conditions, and we transfuse patients optimally to a hematocrit greater than 28. We favor pre-op transfusion rather than intra and post-op. So intraoperatively, we are very judicious about fluid administration. We use cell saver, use myocardial protection, maintain our cardiac index above 2.2. We use antifibrinolytic therapy. Most frequently, our patients arrive on TXA drips to achieve hemostasis. And we minimize the use of blood products. We're very good about stringent glucose control. So glucose less than 180, patients are usually on insulin drips, and we use short-acting sedatives and narcotics. And post-operatively, we use shorter-acting anxiolytics. So patients will arrive on propofol. Everything else looks good. Hemodynamics are excellent, not bleeding. We switch to Precedex if, of course, they don't have any other, heart rate or rhythm issues. As much as possible. We use multimodal pain control. So we use things like Tylenol, Lyrica. If, of course, their renal function is good, they're not bleeding, we can use NSAIDs. And, of course, judicious volume resuscitation. If a patient is hypotensive, we check to see if they're first volume responsive. We don't just keep giving fluids. And we limit blood transfusions unless, of course, their crit drops below 20 or if they're showing signs of myocardial ischemia where you think they would benefit from blood transfusion. So in conclusion, fast-track cardiac critical care, it is a multidisciplinary approach. So the goal is to improve mortality and morbidity and subsequently enhance resource utilization and cost containment. However, fast-track extubation protocols that are currently in existence are very institution-specific. Also, there is really not too many prospective randomized control trials that are blinded because we really need these to develop more standardized protocols and really to be able to delineate any causal relationships between our intervention, which is fast-track extubation, and the outcomes. So this brings me to the end of my presentation. These are some of the references I used in the making of this presentation, and I thank you very much for your kind attention. If there's any questions, comments, suggestions? Okay.
Thank you so much for that presentation. It was wonderful. Just curious as to the audience's experience with fast-track extubation. Are you doing that at all at your centers?
Yeah, Mount Sinai Hospital definitely has a similar protocol to you at Paul's office. And so we actually did really see a decrease in cardiac surgery and extubation times with implementation of the protocol, and then also we put it into Epic as well so that the nurses could quickly see it.
Nice.
Wonderful. Thank you.
Thank you.
Okay, our next speaker is Mackenzie Scott, Associate Program Director, Quality and Safety for Mount Sinai Health System Cardiac Services. He will be talking about decreasing pressure injuries in the cardiac surgery patient.
Thank you, Shauna. So excited to be here. I'm going to be talking about something that isn't so exciting, but is very important and vital to talk about, and that is decreasing pressure injuries in the cardiac surgery patients. So I have about 7 to 8 years of bedside experience in the CTICU where I was a nurse and then I was a nurse manager. And now I work in quality and safety for the Mount Sinai Health System for Cardiac Services. So I've had a lot of experience with pressure injuries. Push this button. So I have no financial relationships. And when I talk about I have experience with pressure injuries, I don't necessarily, and I think Shauna really asked me to speak at this conference because I don't have experience with treating pressure injuries, but I would say that I am a bit of an expert with preventing pressure injuries, which can sometimes be ignored. And I've had a lot of experience with leading efforts to prevent pressure injuries. And so throughout this presentation, what we'll talk about is, we'll talk about defining the problem, why it's really occurring, and I'll go through some statistics. I will talk about how prevention is absolutely crucial, and then we'll just talk about some key takeaways. Okay, so defining the problem. So just some statistics that I found. So the reported incidence of pressure ulcers among cardiac surgery patients, that's at 29.5%. So about a third of your patients that are in your unit right now in the cardiac surgery ICU, about a third of them will develop pressure injuries. Overall, for all of the patients that are hospitalized, we're at 7.2%, so much, much lower. Half of pressure, I found another statistic, half of, overall for patients that undergo an operation, that's at 54.8%. And it's extremely, extremely costly. So patients that develop a pressure injury, it's about $5,000 to $40,000. So it costs a lot of money to treat this, and it's really a call to action to work on preventing pressure injuries in your unit. And so one of the things, that I thought about this presentation was pressure injuries is really the nursing profession's baby. We really have to own it. And throughout my career, I've had a lot of experience in this field in terms of other professions. There have been a few professions that are really interested in preventing them. However, I do feel that, pressure injuries is one thing that nursing really does have to own. And the American Nurse Association does state that the maintenance of skin integrity has been identified as one of the most important indicators of quality nursing care. And one of my mentors really, at a series of meetings, she always said, skin's the largest organ of the body. And so I really do feel that the skin of the patient really tells a story about the care as well. And just this little statistic here, a good takeaway, an average adult skin accounts for above 15% of the total body weight and covers a surface area of approximately 22 square feet. So really, it's an extremely important part that can often be ignored. And this graph is a bit complicated, but it tells a picture that cardiac surgery patients really, out of every single other disease state, is the most at risk for pressure injuries. And you can see this, it's with the development of pressure sore. You'll start here, the support, the posture, but also these long surgeries, the temperature that the patient comes out, it really just does not put our patient population in favor of not developing a pressure injury. So it's really, really a call to action to really focus on this. And sometimes, unfortunately, our patient population is just too sick. They're on too many pressors, they receive too many units. Their temperature remains too cold for too long, and we really just can't prevent the pressure injuries, and that's an unfortunate case. But we do really have to think outside of the box to really prevent them, and I am going to talk about a few of those ways that we can do that. Another thing that, about defining the problem, I was talking to one of my colleagues, and she was going through this presentation with me. I worked really closely with her. And she said, yesterday, I was walking past a room several times, and the patient was in the same position as they were in the morning. And I went up to the nurse, and I asked the nurse, have you turned the patient? And this was in the afternoon, after a full, probably 9 hours have gone by. And the nurse flatly said, no, I haven't turned the patient since the morning. You know, it was really just, that was what was said. And, you know, I think people are shaking their heads now, and I was like, oh my God, this is crazy. But I think this happens all of the time. And it's even more exasperated now because of the pandemic, and because people are burnt and tired. And this requires a lot of work. It's manual physical work, and sometimes we want to focus on the, you know, exciting, interesting cardiac things. But at the end of the day, you know, Shauna would always say to me, you know, we have to remove the blanket, and really just get back to the basics of things and look at things, and, you know, just really focus on this. And that example yesterday really just brought it to the forefront of how there's a lack of accountability as well, in terms of turning patients. So just something to note of really the bigger overarching problem. Okay, so now the fun stuff about preventing pressure injuries. And it really, really is crucial. This is another Shauna quote that she told me. Assessment skills are the essential cornerstone in a nurse's toolbox. And I can't emphasize that enough. Assessment really, really is crucial. And this picture, which was created by artificial intelligence, I thought was really cool, but I really focused on the eyes. And, you know, this doesn't require a stethoscope. It requires nothing except a nurse's eyes to really take that extra effort to turn the patient, lift the leg, you know, look at the sacrum, peel back that mepilex, and take a look at what's going on to prevent the pressure injuries. So just a little tidbit. Another thing that I think is not emphasized enough, and something that has really been a cornerstone of my leadership when I was a nurse manager, and I would talk about it during RCAs and performance appraisals. Did you turn your patient at the change of shift? And did you look at the skin with the other nurse? And we would flatly, you know, say that. And I get it, at the end of your shift, you're tired, you don't want to turn the patient. But how many times have we all, you know, been at the bedside after change of shift and said, oh my gosh, the last nurse missed this? And, you know, anecdotally, as a nurse, I can say from my own experience, I can't tell you how many times I found other things and tried to, and actually prevented other safety errors from turning a patient and lifting back that blanket and looking at what's going on with the other nurse, checking the pumps. So I really, really do think that turning a cardiac surgery ICU patient at the change of shift with 2 RNs should be the standard of care. Something else that I also thought about that, you know, we don't always think about, staffing is always an issue across the country. It's an issue at Morningside, you know, within the health system. When do we have the most nurses in the unit? Change of shift. So, you know, let's optimize our resources. Let's think about that. People need to get into the room and really, really turn the patient, lift back that blanket, and see what's going on to really create safer care. So another thing that, you know, often gets overlooked, and I've done a lot of work on trying to prevent these. And so, you know, this top picture you'll see from the trach ties when they haven't been moved and looked at. The second patient is under a trach, and one of the things that we did for the trach pressure injuries is we worked with the surgeons. One, we created a protocol where we had to remove the stitches within 7 days, and then also we made sure, and some of the surgeons would, you know, get upset with me because I would make sure to remind them, please, please, please put a lyofoam under before you stitch that plate in, because you know, it was so painful for the patients as well. That's another part that we don't talk about, the pain that the patient feels from this pressure. So I would always say, please, please put a lyofoam under, and we also developed a protocol around that. The ears with the nasal cannula, you'll see this often. Please put some Liafoam or some type of sticker around the patient so that, you'll see that these patients, they're just on a little bit of levo, they're up in the chair, but they'll have those nasal cannula on for a long time, and you'll always see the marks when you pick it up. The A-line as well, and also IVs. Please, for a nose, patient's nose, and for nasogastric tubes, please make sure the nasogastric tube is free-flowing. And if you don't have that device that allows the patient, it's a sticker to please make sure that you have it on your units. You also have to involve other disciplines. So I've seen entire patients' lips actually be really, really damaged and almost, they've had to have surgery after because the NG tube just lies on that lip for so long. So one thing that we did is we involved respiratory therapy to make sure that they're helping with turning the tube. So just to reiterate with pressure device related injuries, please establish protocols around frequency of assessment and rotation. And then another thing that I did on the units that I think is a really good takeaway, whenever one of these pressure injuries develops from a device related, please show the picture at a huddle. And I think, sometimes we just don't, as nurses, we don't have time to read everything and go through all the protocols, but showing that picture really sticks in the frontline nurse's head. And then also finally getting other team members involved, like physical therapy and things of that nature. But just anything that's really touching the patient's skin, you want to pull back, you want to change the position, and make sure that you're following up with it. Okay, and so again, a lot of times we like to add things to quality improvement, but yet we don't really think about all of the things and all of the tools that we currently have. So this picture on the right is the Hill-Rom bed. So one of the things that we did on our units is we used the rotation function immediately when the patient came out of the OR, and I made sure, that the patients that weren't being turned as well, which I'll talk about later in my presentation about the no turning conundrum. And then also these Hill-Rom beds also, I found a lot of people don't use the OptiRest. So the OptiRest creates a nice environment for a patient's skin, which can also help prevent pressure injuries. The second the second picture here is a checklist. It's a turning checklist that I created for my PCAs, the primary care associates. And so it's really, really important. The nurses are very, very busy that you make sure that you include your ancillary staff. Sometimes as the shift just goes on, we forget to turn, and it happens to everyone. So what I did is, I talked to the nurses, and actually one of my frontline nurses came up with this, and we put it in the PCA's hands. We said, why don't the PCAs go up to the nurse and remind them of the turn? Because you want to think about the entire work process. And so gathering that PCA to help turn the patient is work in itself. Finding that nurse, getting on that Vocera. So you want to think of how you can decrease the workflow and also optimize the PCAs to make sure that they're turning at the optimal level. So definitely this was a great initiative. And then again, I often find that a lot of times the pressure injury prevention tools are not being used correctly. So a lot of these, this is called the TAP system. So they'll put the bottom pillow device and then the top pillow device, and they'll crunch them together, and then it'll create more pressure because they're not separated. So it has to really go underneath the thigh and then also up towards the back. So again, just something to bring home and to really think about how can we optimize all of the resources. Are we doing things correctly? Let's not add anything. Let's try to just use what we have. And then are we using things correctly is some things that you can take home. So this was really interesting. You're probably wondering why I have an astronaut on this slide. And the arrows connecting to a ventilated patient. And I read this article, the source is here at the bottom, and it talked about how not turning a patient really is truly a problem, and really does affect all of the organs. But what I found in this paper that was really interesting, and I wish I read this paper when I was a nurse manager so I could bring this back to my frontline staff, is that the immobility in the cardiac surgery patient is really, it's like almost being in space because there's no gravitational force. And what astronauts do before they go into space, because they obviously, some of them spend a long time in there, that it does affect their muscles, it affects their organs, and they train for this constantly. And so the article compared a ventilated patient to basically being in space, and how, the training and the turning all goes into really making sure that, we have a good cardiac response, because keeping these patients immobile for such a long period of time really does decrease their cardiac output, especially their muscle mass and also their orthostatic stability. And for the nurses in the room, you'll see this, when a patient comes out and, they're so unstable for 20 hours, and then you'll turn them, and then their pressure completely drops out. So I just thought that was really interesting, and I think, it's something that you can bring back to your units and tell them, this patient is basically like an astronaut because there's no gravitational force going on, there's no resistance at all, and we need to really protect their organs. It's not only about their skin. So another thing that I want to talk about that happens often with cardiac surgery patients is this, a lot of times we'll see a patient's hemodynamics drop, and then they'll be very unstable. And what will happen is, especially on my unit, particularly in Mount Sinai Hospital, I hope this still isn't happening, but the doctor will say no turn for now, right? And then the order will go in, and that will happen repeatedly. And I've come on my shift, this will happen, let's say a no-turn order goes in on Friday, I'll come in on Monday, and still that patient hasn't been turned. And no one's really assessed, can we move this patient? And so I really want to advocate, and it really takes a lot, and that strong nurse or that strong team member to say, are we moving a patient? And then also, when a new no-turn order is placed, how long are we going to do this for? What's the next time for assessment? We can't just put in a no-turn order and then walk away and just say, oh, we're not going to turn, we're not going to do anything. So you really have to think about that when a no-turn order goes in, and what are the consequences. And then also, I just put this protocol, this is, just something that when a no-turn does happen, that they did this whole study, and what they found is that a lot of times, when we do turn the patient, we'll get so scared and the alarms will go off, and the patient's blood pressure will bottom out. But to really just stay calm, and it's okay for a 5 to 10 minute period. And they did this whole study, and what they found is that there was actually no safety events whatsoever. Also, I just want to re-advocate that lateral rotation does help. It's not for in place of turning a patient, but lateral rotation definitely helps, so please use the bed. Also, just lifting a leg up and moving a patient and using that range of motion really should be instituted, especially when there's a no-turn order, because that does take the pressure off of the sacrum. So please, please, please think about that, and then when that no-turn order does go into place, please speak up and say, guys, how long are we going to do this? When's the next time we're assessing? Please don't just let this go on. So another thing is, this really does take a team, and so I recommend weekly rounding among leadership. So one thing that we did at Mount Sinai Hospital is we did Wound Wednesday, and then you also want to come up with a standardized tool. So we used REDCap, but you can use any type of paper form or anything. But you want to create a standardized tool that will then prompt action. So you can't really see it here, but one thing that we were finding is that patients were sitting in a chair for a long period of time, and no one would lift them up, and then their bed, their sacrum would be completely red. So we put, and this was created with our unit-based counsel, we put on this tool, is there a cushion underneath the patient? So it's just simple questions like that you want to create to prompt action. Because too often I find that with a lot of audits, we're just putting down the answer and then there's no response. And then you want to make sure that these leadership rounds are action-oriented. So it's not just about going to the nurse and saying, like, all of these things aren't done. But one thing that we did at MSH is we would really correct it at that point in time so that we were able to follow up. Because a lot of times the follow-up didn't happen just because all of these various things would happen on the unit, emergencies, et cetera, et cetera. So really important to follow up in that real time and then also to create that standardized tool. So just some key takeaways that I really want to drive home. Assessment is essential to preventing pressure injuries. Please, please, please use your eyes. Get into that room at change of shift. Advocate for 2-person RNs to check the skin at change of shift. Think outside of the box for patients who cannot be fully turned. Can we lift their leg? Can we do lateral rotation on the bed? Anything really to mobilize the patient, because if they're just laying in that bed for a long period of time, they will develop pressure injuries. Yes, we all know that, but their organs will also be impacted. And then finally, before you add anything, think about really optimizing your resources to the best of your ability, right? When do I have the most staff on the floor? Change a shift, right? So let's get into that room, make sure that we get that turn, because unfortunately, I really do believe that there is an accountability problem with this. One, because it's very hard to monitor for a nurse leader, if we are turning the patient every 2 hours. So really, really, it's important to optimize your resources. And that's all I have. Does anyone have any questions or comments for me?
I was wondering if you were familiar with the TurnCare Guardian system. It's a
Not, but is that similar to some type of, it monitors the turning?
No, it was developed by a cardiac surgeon who had a patient die from, a sacral decube complications. And it's a new device, and I'm familiar with it because we have so many patients now that are on ECMO, they have Impellas in, and the no turning order comes through. It's a device it's a pad that goes under them. It can go on any bed, and it also goes on the chair. And it has little pockets of air that senses where pressure is and changes how much air is in these little squares of pockets. And it increases blood supply to the sacrum and the back and the upper thighs. Same thing when you're on the chair. And I was just curious if you've come across that.
No, we haven't, but Shauna and I are definitely going to look that up on Monday.
Yeah, I have no financial
No. One thing that
disclosures about it.
Yeah.
At all.
One thing, so we have looked at, I have looked at various things that can, and problems with bringing a lot of this technology is, and Shauna and I did go through a pretty lengthy, I think, process and business plan for a leaf sensor. Has everyone in this room heard of the leaf sensors? Which we thought was great. However, as we all are aware in this room, the healthcare system is going through, not just Mount Sinai, but everywhere, a lot of financial conundrums. So getting these items passed through is very, very challenging. But that sounds like a great device, and we're willing definitely to look into it. And I have seen other things that you can put in under patients while they're in the operating room.
Yeah, this can be used in the operating room. The console sits on just one of the side rails.
Yeah.
And there's no capital cost. We still have not gotten it into Jersey Shore University Medical Center. It's still up in the decision making in corporate, and you just rent it when you use it. So you select the patients that may need it, and you put it on. But
oh, that may be easier.
they have a couple good studies out that are impressive.
Yeah, that was something that we did with the leaf system when we were working on it. We made criteria because of the expense you couldn't use it on everyone who had a Braden score less than 18 because that's the majority of most people. Because if you're NPO or you're not really walking, you're on your Braden's going to be 18. So we did develop a criteria, and I know Mallory and Marcy was also instrumental in that we picked certain patients who were prolonged ventilated, because when you come out of the OR, your Braden's going to be 18, but if you're fast track, that's only going to be a temporary situation. So we did create this criteria for prolonged intubation if you were on multiple drips for a long period of time, so high dosing, to actually target when you can use the leaf system instead of just putting it on everyone, which sounds somewhat similar to what you were utilizing. But unfortunately, it kind of got stopped at the top, and hopefully we can revisit it.
Yeah.
Because I think the leaf, what's great about the leaf, it's not really going to prevent the pressure injury. What it's going to do is hold the accountability, because you'll be able to run reports to see if the patient was turned, if they were turned every 2 hours, and also it will tell you if they have properly offloaded. When Mackenzie showed the pictures of the pillows, if you can use those pillows, but if you're not using them correctly and the patient's not properly offloaded, you might as well not even use the pillows. So the leaf also helps to maintain proper offloading too.
Yeah, and then another problem with the leaf was there was a lot of technical issues
Yes.
that went in. There's a lot of technology that had to go on in the background. And there was a lot of overhead in terms of, it was a big financial thing that we had to go into, but.
I think Laura.
I just wanted to mention, like, the term micro turns. Like, I know that we sometimes try to implement that as well at the bedside, especially when patients who have the no turn order, like, and they're soiled, like, there's either like blood or a bowel movement underneath, and like you can't really turn them because if they are like hemodynamically unstable, just having them like slightly turn, and then that's when I was able, like when I was at the bedside, to assess the skin and be like if there's an injury or not. So I don't know if that's
We used to have this, I think we still have them, the Z-Flow.
yeah.
So the Z-Flow is great for micro-turning, so even if you offload someone by 10%, and it's not really a full turn, you still help the skin when you have an open
Yeah.
chest or you have an ECMO, or you really have a patient hemodynamically unstable. So micro-turning is really important as well. I don't think that many people know about micro-turning.
Using underutilization of the,
That's okay. I don't think a lot of people know about the micro-turning. It's an underutilized technique.
Yeah.
No, but I think, going back to your point about the OptiRest feature of the bed, I think it's so underutilized.
Yes.
And people don't understand what does it do? It alternates, just like your system kind of sounds similar, but it alternates the pressure. That patients complain, I feel like I'm on a boat, stop this thing.
Yeah.
Yeah. So I think that getting nurses to do that more frequently would also help reduce this.
Another thing
Can't move.
I just want to mention, with pads, less is more. Please do not put extra pads underneath a patient. That really does create not a good environment for preventing a pressure injury.
Yeah, all nurses are about pressure injuries, clearly, because this is the most conversation we've had since the beginning. All about pressure injuries.
Okay, thank you, thank you.
Thanks, Mackenzie. So our next presenters are Christina Choi and Nikki Lee, who are both staff RNs in the cardiac surgery and CCU. And, oh wait, what? Does it say lunch? Okay, I guess it is lunch. Okay, I'm just wanting you guys to go.
Just a few housekeeping issues. Sorry, I know I'm 2 minutes away from lunch to hold you back. I want to thank you all for attending this morning's conference, and I want to thank the presenters and the directors for putting together this program. And it was a wonderful experience, and it further drove home our rationale to create a team approach conference, because every presentation really drove home that we all work together. Whether we're in the operating room, whether we're in the office, whether we're seeing patients in the unit, on the floor, or seeing them back in the clinic after surgery, we all work together and participate, because this patient care is very complicated, right? Just listening to the presentations and everything that's involved.